Wonderful. All right. So, good morning, everyone. As Harry said, my name is Ashley Morgan, and I am the director of the Substance Use Deflection Initiative here at NEOMED. We're in the Criminal Justice Coordinating Center of Excellence. So, thank you so much for letting me join you today to talk about this. This is a topic that I get really excited about. A little bit about my background. I am a licensed professional clinical counselor with a supervising credential and a licensed independent chemical dependency counselor. And I've been in the field for about 20 years. So started in dual diagnosis treatment, residential treatment for women. I've worked in university, college counseling centers, intensive outpatient programs, and outpatient programs. I've done research work around the implementation of evidence-based practices, and now working in the Coordinating Center of Excellence. So today, we're going to take a look at some practical ways to support people with both substance use and psychosis using person-centered harm reduction framework. So my goal today, or our goal today, is to focus on what works to keep people engaged and really moving toward recovery. So we know that about half of individuals experiencing psychosis also use substances. Some of the common ones, cannabis is commonly used and it's linked to earlier onset of symptoms, linked to relapse. Alcohol often shows up kind of later as self-medication. Nicotine is heavily used. Individuals with schizophrenia use nicotine at 4 times the average when we compare it to the general public. And with substances, substance use can be both a risk factor, but it's also a coping strategy for a lot of individuals. So when we're seeing use, it's not always about resistance. Sometimes it's a symptom, sometimes it's about self-management. And substance use itself is a predictor of disengagement. So just the use itself, and also it can affect some of the other dropout risks, like whether or not someone gets involved in the criminal justice system, whether or not they're adhering to treatment or compliant with medication. But engagement itself is really therapeutic. So everything that we can do, everything that keeps someone connected really improves treatment outcomes. We can't help people who aren't with us. When we lose engagement, we lose the therapeutic opportunity. So our first goal is to really keep the door open for individuals whenever we can. And it's completely understandable that a lot of us might start from an abstinence mindset. We've seen the damage substances can cause, how they can exacerbate psychosis and other health factors. And we really want to protect our clients from further harm. Wanting people to stop using comes from a place of care. It can come from a place of urgency. The challenge is that when we lead with abstinence as the expectation for people or for treatment, that the people who might need us most may step away before we can help them and can make recovery less accessible rather than more accessible. This kind of framework raises dropout rates. It can damage trust. It can undermine rapport, maybe delay recovery. I recently heard someone say that if our model of treatment only works once someone has stopped using, then it's not really treatment, it's aftercare. And that really resonated with me because in thinking about what other diseases or disorders do we require that the symptoms are resolved before we begin care. So the question here really becomes, how do we keep people safe and engaged long enough for change to happen? Readiness for change is the strongest predictor of change. So our work is to enhance readiness, not to demand it. We should really be meeting people where they are and not leaving them there. That doesn't mean that we're endorsing use. It means that we're staying close enough to the person to influence behavior around use. And every small step towards safety or stability or insight really is treatment progress. So everything that we've talked about so far, meeting people where they are, enhancing readiness, supporting the change process, staying engaged even when someone isn't ready for abstinence, that all has a name, that all falls under the umbrella of harm reduction. And I know that can feel loaded. It may feel loaded, especially kind of now, but people are often associating it with things like syringe service programs or naloxone distribution, which are both really vital. They're evidence-based interventions, But I also want to emphasize that harm reduction is much broader. And it's not a philosophy of permissiveness per se. It's really a clinical framework that guides how we can engage people, not whether or not we like their behavior. And it mirrors some of the core values of cognitive behavioral therapy for psychosis, that autonomy, that shared decision making, empathy, dignity, respect. It's recovery oriented. And SAMHSA defines recovery as a process of change. So, improving health and wellness, living a self directed life, striving to reach one's potential. So, harm reduction is how we keep people safe and connected long enough for that process of change to happen. I can't emphasize enough that it's a process of change. And there's one strong overarching myth related to harm reduction that often results in people feeling uncomfortable with it or objecting to it. And that's that harm reduction encourages or enables use or using behaviors. At the literature, what we know is that harm reduction actually acknowledges autonomy and it builds safety until readiness increases, which readiness is that predictive factor around success. Harm reduction increases the likelihood that someone will enter treatment and achieve abstinence. It reduces negative outcomes not only for individuals, but also for their communities. It reaches people that conventional treatment rarely does. And it also improves provider satisfaction. So it's not only good for the client, it's also better for us. And in reality, harm reduction embodies so much more than substance use. If we think about it, think condoms, sunscreen, seatbelts, helmets, healthy diet, healthy exercise. That's all harm reduction. And we're doing that and talking about that kind of stuff every day. So now that we've kind of laid the foundation for what harm reduction in person-centered care looks like, in principle, I wanted to briefly shift into some models and programs that support individuals who experience psychosis and substance use. And I'll start with a quick nod to cognitive behavioral therapy for psychosis, just briefly because you're all familiar. So this is an evidence-based approach. And again, many of the core elements, collaboration, autonomy, being recovery-oriented, these naturally reflect that harm reduction and person-centered, those principles, even if we're not always using that language. And CBTp really sets the stage for some of the other models that are more explicitly integrating substance use treatment. As you guys know, because you're here, the Best Practices in Schizophrenia Treatment Center has a lot of excellent tools and resources to help with the implementation of this. One of the best supported models for addressing substance use alongside of psychosis is integrated dual disorder treatment, or IDDT. So this is also evidence-based. It's stage of change driven, it's motivational, it's time unlimited. So in practice, that really means that we don't discharge someone when relapse happens. We're staying engaged and we're always adjusting to the person's readiness. Case Western Reserve University's Center for Evidence-Based Practices has some excellent training and tools around this, which includes a stage-based decision guideline that helps to match interventions to a person's stage of change, incorporating psychosis into the equation. And I just wanted to briefly show you this. This is linked in the slides that you guys will be able to access. So as you can see over here on the left, it goes by kind of the stages of change. So engagement is pre-contemplation, the early motivation stage is contemplation, late motivation stage is preparation. And with each stage, there's a series of things to consider or questions to ask. So with this pre-contemplation, we're looking at, is someone in crisis and what do we need to do to navigate or resolve crisis? Are there additional services that are needed? What are some of the basic needs that may be missing that we need to ensure that we're getting into place? Are we building rapport in the relationship? What other things do we need to assess? Next, Can Talk is another program. It's designed for youth and adults with psychosis who use cannabis. It uses motivational interviewing and stage of change approach to help people explore their use. So the program is manualized. You can see a page from the manual over here on the left. And there's also a companion discussion guide. You can see that over here on the right. So it supports both the clinician and the client through the process of guided reflection, through insight building, through goal setting. Another approach, the community reinforcement approach, or CRA, is an evidence-based practice. And while it isn't specific to psychosis, it is consistently successful with a range of substance use issues. So I included it here because it provides a really solid framework for a lot of the skill building strategies I'm going to talk about in some of the later slides. And the basic idea behind CRA is that people are more likely to change when their environment, when their daily life, when those things feel rewarding, when they make recovery feel rewarding. It's built on the principles of operant conditioning. So we're helping people kind of gradually replace substance use with healthy, meaningful activities that feel good, that connect them to others. Um, Again, wanted to show you some resources and tools related to CRA, and also highlight that there are various ways that CRA can be approached. So there's an adult approach, there's an adolescent approach, and there's also a family approach. So again, this is linked in your materials for resources and training. So the skills and strategies that I'm going to discuss next show up across all of the approaches that we just talked about, but they're also grounded in motivational interviewing. And I think it's important that we talk about matching interventions to a person's state of change. We often lose people because we're intervening at the wrong stage. And that's often when we see resistance appear. And resistance isn't usually defiance. It's often a signal that our approach is mismatched, that we're not meeting the client where they are, we're not hearing them. It tells us we're ahead of the client, or maybe that we're imposing our own goals or ideas into the clinical space. So our task is really to adapt and roll with resistance, not to persuade the client. So we want to become really familiar with the stages of change, what they look like, what the goal for each stage is, how to match appropriate interventions to each stage of change, and some of the signs that you can move on to the next stage of change. What do we want to see within our client to know, okay, we're moving forward. So in pre-contemplation, the person's not seeing the problem yet. So the goal isn't for them to develop insight, it's for us to build a good relationship. So building rapport. There's no plan to change here. Success in this stage really is about, again, building rapport, creating safety in the relationship so that honest conversation about use can happen, even if the person is still seeing more pros to their use than cons. And just remember that the pros can really help us understand what's driving the behavior, and it's information we're going to need later anyway to help with change planning. And we're also in this space trying to find the motivational hooks that we can use to start connecting to things that help develop discrepancy and help grow insight in some of the later stages of change. So interventions here might include managing any acute crisis, building rapport, learning what's important to the person, assessing their readiness to change. A lot of what was on that stage-based decision guideline that we looked at a couple of slides ago. Completing a functional analysis of use or pro-social behaviors is also a good intervention at this stage. So that means we're exploring what purpose does use serve, what else provides that function, what activities feel rewarding without use. And you can move forward from pre-contemplation once you see that someone is starting to acknowledge sort of the downsides of their current use. Again, wanted to show you this functional analysis tool if you're not familiar with it. So there are three types of functional analysis. There is functional analysis for use, for relapse, and then for pro-social behaviors. For use and relapse, both of these look very similar. For pro-social behaviors, that's looking more at sort of positive reinforcement of some of these meaningful activities. But with use and relapse, we're looking at what are some of the external things that are happening in the environment that are tied to use? What are some of the internal things that are happening, feelings, physically and emotionally, thoughts, so that we can do some recovery planning or relapse prevention around those pieces. Behavior, so we're assessing what's happening, the short-term positive consequences. So we're looking at what is the person gaining? What do they like about the use so that we can start to find ways to kind of replace or modify those behaviors. And then the long-term positive or long-term negative consequences are where we can also start to find those places to develop discrepancy or those hooks that might be motivational hooks. Moving into contemplation, we see that the person is starting to weigh pros and cons. They might be gathering information or starting to explore some mixed feelings. But again, there's not a plan for change yet. The goal is really to explore ambivalence safely. So we're not pushing for a decision, and we're working to start to develop discrepancy between what their goals are and what the values are and their using behaviors. So interventions here might include decisional balance exercises, readiness rulers. You might use an ongoing functional analysis to continue to explore some of this stuff. Tools like the values card sort to help people identify what really matters to them and whether or not their behaviors are aligning or conflicting with those values. And you can move on when the person decides to act or starts to test out new behaviors. Again, this tool around the values card sort, if you haven't done one, there's an online version that I really like where you're able to just sort what's important, what's somewhat important, and then what's most important. And once someone has narrowed down what's most important to them, you can start to look at that compared to how their use behavior either aligns or doesn't align with it. Again, giving you opportunities to develop discrepancy. With preparation, the person really intends to change. It begins taking small steps in that direction. The plan is for them to change in the next 30 days. So the goal for this stage is to support and encourage those steps. Interventions might be in helping them to set small goals, offering a menu of options that would support those goals, offering psychoeducation, developing a change plan, connecting to supportive resources and supports, and helping to prioritize needs. And meeting ambivalence with curiosity rather than correction can really preserve engagement. And you can move forward from this stage when the person has set some clear goals and some priorities for change. Now we're in action. The person has made the change, we got there, and the goal is just to reinforce these new behaviors and build relapse prevention skills. So interventions would include skill building, practicing skills around coping, drink drug refusal skills, communication, problem solving skills. We want to build a relapse prevention plan, a recovery plan. I really like using a wellness recovery action plan when someone has dual diagnosis, helping to make connection to recovery supports. And we're affirming often, which really helps to reinforce self-efficacy. And you can move on when the person has sustained these changes for 6 months. We're moving into maintenance, which means that the change has been sustained for 6 months or longer. And our goal is ongoing support, it's problem solving, it's continued growth. Interventions would again be to affirm and reinforce self-efficacy. We want to explore any emotional or situational barriers that are coming up and update the relapse prevention or recovery plan accordingly. Encourage and support the pursuit of meaningful activities. This might be a really good time to revisit that values card sort, ensuring that behaviors are aligning with goals and values. And we know that recovery isn't linear. So in this relapse stage, the individual has returned to old behavior after a period of change or abstinence, and this can happen, throughout any stages of change. This is really common. It's considered part of the process rather than a setback. It's not a failure. It's really good data. It's good information. And it's important to remember that our tone and attitude, which hopefully is non-judgmental and compassionate, can really determine whether or not a person re-engages or disappears. It can also determine how they frame the relapse for themselves. So our goal is to help them learn from the relapse and re-enter the cycle of change at appropriate stages. Usually it's preparation or action, hopefully with new insight and new strategies. Interventions might be around assessing for crisis if a relapse has happened, normalizing and encouraging self-compassion. We might do a functional analysis of relapse here, strengthen coping skills, highlighting past successes, updating the recovery plan, and you can move forward into whatever stage of change. Once the person acknowledges that relapse, they're regaining motivation and they're re-engaging in planning for change behavior. So again, here's a list of tools from the conversation today that are linked here. So to wrap up, harm reduction isn't the opposite of recovery. It's how it starts. It is person-centered, so it's that bridge between engagement and recovery. Readiness, not compliance, is the predictor of change and success. Meeting people where they are and not leaving them there is the essence of person-centered care. And just remembering that we really have the ability to drive change when we are able to employ these principles. So there's some references here that you guys can take a look at if you're interested. And I think that's all that I have. If anybody has any questions. I also want to share, if this is an area of interest to you, the Deflection Initiative does do a deflection echo. It's the second Thursday of every month at 1 o'clock. I would invite you guys to join. We do a lot of substance use related topics there.
Perfect. Thank you, Ashley. Wonderful presentation.